Thanks for the invitation and those kind comments. Anyway, this room should be packed, quite frankly, because this is good stuff here tonight, this morning. So anyway, I'm going to talk about something other than vascular and some real-life complications. So this is what I'll be talking about, and let's just run through some of these. So Chris Zachary the other day said he guarantees post-inflammatory hyperpigmentation with darker skin types. So this guy came in to see me for treatment of his acne scars, and he wanted a one-and-done procedure. So, well, I said, let's do the ablative fractional, and of course he gets PIH. And I think PIH is eminently treatable. And for those of you who saw the article in JAMA Derm from a few months ago, where there's an editorial saying that laser should not be used on the face for pigmentation, of course, I went nuts and wrote a reply, which was published after a significant amount of effort, saying that I think it can be done. Here's an example. And what we did here is we used a low-energy, low-density, non-ablative fractional. This was the LASE-MD. It's a thulium laser, lower energy and lower density than what you would have with the Fraxel laser. And I think there's a difference here. And the difference is, and you'll see in this particular photograph, that there are differences in terms of the size of the microthermal zones and the density of the zones and the amount of energy, and I believe that the lower energy, lower density allows us to treat the PIH more effectively. So let's go back to this one. This is a patient who came to see me, had some type of birthmark that was hyperpigmented on the buttock. And here again we use the LASE-MD, low energy, low density, non-ablative fractional. I think that the thulium laser, the Fraxel itself at 1927 and other wavelengths, Q-switch lasers, picosecond lasers, are very, very problematic in treating this type of hyperpigmentation. But you can treat these patients. It does require multiple treatment sessions. We're relatively conservative, looking for some erythema. They do get the mens after the treatment, these little pepper spots, but this resolves over time. So, and here again, you can see if you look microscopically, or actually this is OCT on Jordan Wang's arm, the difference in these microthermal zones showing that they're not all the same, and that with the lower energy, lower density LASE-MD or even the Clear and Brilliant, much safer for treating PIH, so I think it's an important pearl. We've heard about post-inflammatory or post-laser hypopigmentation. Here's a patient who had some resurfacing done on the extremities, leading some hypopigmentation. Here we use, again, this is actually the Fraxel dual used to stimulate some hypopigmentation, and we do use this in conjunction with some topicals with tamiprost, which can be helpful. This does require multiple treatments, but I do believe that the treatment of hypopigmentation is something that's viable and effective. Now, this is from an IPL on the top part. Fortunately, we don't see this as much anymore with the new high-frequency treatments with IPL, where you're going over the area multiple times, so you don't leave these rectangular areas of hypopigmentation. So here, with the Fraxel dual at 1550, we're able to induce pigmentation. So we're able to do this at both 1927 and 1550 to help. Yes, these things do resolve to a large degree over time, but living in New York, people don't want to wait. They want their problems addressed quickly and effectively. And some patients, so this is post a fully ablative resurfacing procedure, left with some hypopigmentation. We did not correct this completely, but I did use an ablative fractional CO2 laser very, very conservatively, use the tamiprost afterwards, able to see some improvement in a single treatment session, something to keep in mind. One of the problems that we can sometimes see, particularly with these new microblading tattoos and the really explosion in the use of the cosmetic tattooing of the eyebrows, is some paradoxical darkening. So here you can see that the area turned darker, and subsequently we're able to treat that. So we began with a 532 laser, it turned darker, subsequently treated with a 1064, and I've done this the reverse as well, but it's a way to treat these patients and not leave the patients with the permanent darkening that you would see in treating these odd colors. What we're doing now in many of these patients, particularly some of the dark tattoos with the microblading ink, is they look like a dark tattoo and they turn red right away. So we're treating with a 532, starting off at 1064 with a picosecond laser, following through with the 532 at the same treatment session, so they don't have to walk around with red, yellow, or orange eyebrows until you bring them back. Now, paradoxical darkening can also occur. This patient went to a spa and had a pink tattoo, treated with a Q-switch laser, which turned it black, and this odd red color, sort of reddish-black color. So here we used a very conservative, fully ablative CO2 laser. In today's world, I probably would have used a picosecond laser at 532, but I didn't have that at that point in time. So very conservative ablative fractional. If you get too aggressive, you're going to create a scar. But here I was able to remove this very conservatively without leaving any scarring. This is one that was a real challenge for me. I didn't see this coming. If you look on your left, you can see the original tattoo that looked black, and lo and behold, the thing turned pink right away. And then we ultimately went back and treated her with a 532 nanometer laser, which was able to clear it. But you know, at the time, I wasn't sure whether there should be left with this reddish ink, but fortunately, we were able to treat this with the Pico Plus 532 nanometer laser. We've seen a number of these this morning, post-resurfacing scarring. Again, I think the way to get to these patients, if they're your cases, is to catch them early. We follow our patients very, very carefully. If I do see some induration, persistent erythema, then I'll treat them very, very soon, as soon as I see that. And I also treat them regularly. I see these patients back every week. I also inject mostly 5-FU, a little bit of triamcinolone. We have them use silicone gel, and when necessary, or when available, or when, if they're willing, treat them with some massage as well. This patient also had the contracture that Matt showed around the mouth. We were able to release that quite well. So early intervention makes a big difference. You can prevent these scars from becoming permanent. Whoops. So this patient had a traumatic injury with traumatic tattooing, and she went to a surgeon who decided he would dermabrade the traumatic tattoos. I don't have that original picture. So this is unnecessary. Traumatic tattoos can be safely and effectively treated with lasers. So this patient came to me. We did a series of treatments with the pulse dye laser. We did some ablative resurfacing below the brow to improve those scars. And this responded quite well. But just to show you that these traumatic tattoos can respond quite well to a laser treatment. You don't have to dermabrade these. These absolutely should not be dermabraded. But here, at I think 3 treatment sessions, we've been able to remove a significant portion of the traumatic injury that he sustained. This was from some type of explosive on July 4th that blew up in his face. Here, this is a green tattoo on this little kid's lower eyelid. This is with a Pico Shore laser at 755 nanometer laser that worked quite well in a single treatment session. So again, don't dermabrade these, appropriately suited for laser treatment. I want to close with one potential pearl, and I have an N of 1, but it was so interesting that I think it's worth sharing. Most of us know that paradoxical adipose hyperplasia is a big problem with cool sculpting. Fortunately, we're seeing less of it than we did years ago with the newer applicators. But when it does occur, it's problematic. And I have a patient, not this patient, who would not let me release her slide. She had paradoxical hyperplasia from 5 or 6 years ago. She tried liposuction several times. Nothing worked. And I put her on Dupixent. And the paradoxical hyperplasia has melted away. So I wish I could share those images with you, and it's an N of 1. So if anybody else experiences this and wants to give us a shot, I'd love to hear about it, and I'm sure Allergan would as well. Thank you very much.
What was your thought for that with Dupixent?